بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is the second part of the white matter diseases, the imaging of the white matter diseases. We have discussed in the first part of this talk the congenital white matter lesions, the leukodystrophies, and now we are going to discuss the acquired white matter pathology, and we will talk about the famous multiple sclerosis and some of the viral infections in the form of acute demyelinating encephalomyelitis. Then we will have some words about toxic demyelination, including the osmotic myelinolysis and vernix encephalopathy, as well as the effect of radiation and chemotherapy on the brain tissue, particularly the white matter. Then we'll handle some of the traumatic impact on the white matter, which is the diffuse axonal injury. And finally, we'll talk about this very big topic, which includes all these pathologies. You remember we have handled the hypoxic ischemic encephalopathy in the pediatric age group, and we talked about the periventricular leukomalacia in the preterm neonates, and also we discussed the full-term pathology, including the watershed infarctions. But here we will deal with the subcortical arteriosclerotic leukoencephalopathy and the multi-infarct dementia. And the CADASIL is an entity of multi-infarct dementia. Then finally we'll end by some words about the effect of vasculitis on the white matter, including the moya and some of the other lesions like systemic lupus erythematosus and Behçet disease. We start by what's known as the normal brain imaging. We use teleported CT and MRI of the brain of an old person, as there is some ventricular dilatation and exaggeration or prominence of the extra axial CSF spaces. And frequently, if we are talking about the CT, we may mention that there are some increase in the hypodensity of the periventricular white matter, suggesting a subcortical ischemic changes. But in the recent literature, we see that these describe the changes in the white matter are present in healthy patients as well as in patients with dementia. And if you see an MRI of an old person at the age of 60 or 70, then you will see these changes while the patient looks normal and they are thinking normal and he has no motor or sensory deficits. You see that the ventricles are dilated if you are talking about MRI, and you see in the periventricular white matter foci or patches of increased signal in the T2 and the FLAIR weighted images. And most of these lesions will not show diffusion restriction. They are not surrounded by edema and usually exert no mass effect. Also, you can see that there is a rim of high signal intensity in the FLAIR images particularly, and this is also considered a normal finding or a normal brain aging. And if you look here, and this is the FLAIR image, and you see the ventricles are dilated, the cortical sulci are prominent, denoting the presence of involutional brain changes which are accepted for the age of the patient if he is in the 60s or 70s. Then the presence of a rim of high signal intensity framing the ventricular wall is a common finding in old age, together with multiple foci and batches of increased signal intensity in T2 and FLAIR-weighted images. As I have mentioned, these foci are not surrounded by edema, they do not exert any mass effect, and they show usually diffusion, no diffusion restriction. In this age also there is increased iron deposition in the basal ganglia. Then if you look here and you see this is an axial T2 and this is axial T1 post contrast and T2 and the flare. And you see here in the white matter there are batches of high signal intensity in T2 and in the flare images. And also you can see the foci of abnormal signal in the basal ganglia. These lesions will not show any contrast enhancement. They are not surrounded by edema and exert no mass effect. Then we usually say that these lesions represent small vessel disease or ischemic white matter changes which are related to the presence of arteriosclerosis, which is a common finding in old age. And the lesions will be related to the age, and they will be more evident and more sizable in patients who are hypertensive and diabetics, or those who have a heart disease, like ischemic heart disease, for example. Then we consider, and these lesions are considered to represent white matter ischemic areas or infarctions. Then we have this well-known anatomic structure, which is known as the perivascular space or the Virchow-Robin spaces. These are extensions of the subarachnoid space, meaning it contains CSF and it extends around the penetrating vessels through the brain tissue. They enter the basal ganglia and the cortical gray matter in the high convexity of the brain. The presence of Virchow-Robin spaces is considered as a normal variant. It can be seen at all age groups, and the Virchow-Robin spaces may be, become prominent with advancing age. And this is a good example. This is T1 and this is T2 with the images showing the Virchow-Robin spaces in the form of dots of CSF-like signal, low signal in the T1 and high signal in the T2 weighted images should not be mistaken for lacunar infarctions, for example. These are normal variants or normal anatomic structures which are commonly seen in the region of the basal ganglia bilaterally. They may be symmetric or asymmetric, and also in the white matter of the high parietal areas. And with advancing age, you see that the Virchow-Robin species become more prominent and sizable. And here, this is the flare image. The Virchow-Robin species contain CSF. They will appear black in T1 and the flare weighted images, and they will show bright signal in T2 weighted images. And many times you can see the abnormal prominence of the Virchow-Robin spaces in normal conditions, but you remember the spongiform pattern of leukodystrophy we have mentioned before, and also in some cases of mucopolysaccharidosis, the Virchow-Robin species will be distended by mucopolysaccharides, and they give this classic appearance with evident prominence of the spaces. Then we came to the famous multiple sclerosis, and this is considered the most common demyelinating disease acquired pathology after the vascular and age-related demyelination. It is considered as an autoimmune mediated demyelination, and the age incidence of this disease ranges between 20 and 40 years of age. And we all know that the MS is a clinical diagnosis. Imaging is just to confirm the diagnosis and to follow up the disease response to medical treatment. And the MRI findings of multiple sclerosis are almost characteristic. Number one, you should see a patient in the age reasonable for MS or common for MS to develop, which is between 20 and 40 years of age. Then the disease, as you all know, has more predilection to females more than males. And if you see the lesions or the lesions, the plaques of multiple sclerosis will appear of low or iso intense signal in the T1, high signal in the T2, and the flare weighted images. And they are characteristically arranged at the callosociptal interface, and they are perpendicular to the ventricular wall, giving the typical appearance of Dawson's finger. And some lesions commonly appear in the posterior fossa. It is usually stated in the literature that we should have three lesions or more that are 5 millimeter or more, and in order to settle down the diagnosis of MS. But as I have mentioned, the diagnosis of MS is a clinical diagnosis. It in the literature there are some stated criteria for the imaging findings in order to say that this is MS. But in all cases, the diagnosis of MS will depend on the clinical picture and the neurophysiological studies. And the lesions are characteristically present in the deep white matter at the callosociptal area near the region of the corpus callosum, and they are perpendicular to the ventricular wall. And sometimes the lesions will show enhancement, and enhancement is variable and transient, and is usually an indication of activity in the disease. Some of the MS plaques may be large so that they mimic a neoplasm or an abscess. And this is the classic appearance of MS in the uh, axial T1 post contrast, axial flare, and the T2 weighted images, and this is flare also. You can see here multiple periventricular foci of abnormal high signal in the T2 and the flare weighted images deeply seated in the periventricular area, and there is some enhancement in the larger lesion in the left deep parietal region. And this is the case of MS in a female patient 30 years old with extensive MS plaques that are deep in the periventricular white matter, perpendicular to the ventricular wall. Some lesions are sizable, as you can see here. Larger lesions can appear of low signal in the T1 and will be bright in T2 and the flare weighted images, while smaller lesions may not be seen in the T1 weighted images. As I mentioned, that the diagnosis depends mainly on the clinical picture and in the neurophysiological studies. And if you see enhancement in one or more of the lesions, you may predict that the lesions are active. And this is a male, 25 years old, who has MS, and you see the plaques in the periventricular area of high signal intensity in the T2 weighted image. Some of the plaques will show enhancement like this one and this minute focus, and also this one, which is an indication of activity. And you know that the plaques may affect the cord only, or the brain only, or both. And the incidence of brain and the spinal cord involvement in the same time is almost in the range of 30%. And some of the MS lesions will be sizable, and they will show low signal in the T1 and high signal in the T2 and the flare weighted images. And after injection of contrast, they show this very classic pattern of enhancement, which is in the form of an incomplete ring. You see, there is marginal enhancement which is not complete in this particular area, and this is one of the criteria to separate this type of MS, which is known as the tumor-effective MS, similar to the tumor, from tumors and abscesses, since the glioblastoma multiforme, for example, may show similar enhancement, and also the brain abscesses may show similar enhancement. They are both surrounded by perifocal brain edema. And this is also a case of a tumor-effective multiple sclerosis, showing the typical appearance and enhancement. The lesion is of high signal in the T2 weighted image, and after contrast injection, there is incomplete ring of marginal enhancement as seen in the axial and the coronal images. And this is also a case of tumor-effective MS, showing low signal in the T1, high signal in the T2, and the classic incomplete ring of marginal enhancement. Then we came to the inflammatory white matter lesions, and here we would like to discuss the ADEM, or the acute demyelinating encephalomyelitis, which has been discussed many times before when we talked about intracranial infection in adults and intracranial infections in the pediatric age group. It, ADAM is a white matter inflammatory disease due to an autoimmune phenomena, and it will simulate many times the appearance of MS on imaging. But there are some of the criteria to separate both from each other. And the first one is, for the diagnosis of ADAM, you should have a history of viral infection or recent vaccination about 10 to 15 days before the onset of the disease and the appearance of symptoms and the change in the MRI or the brain scans. And the lesions will appear similar to MS plaques. They are of iso-intense signal in the T1, high signal in the T2, and the flare weighted images affecting the white matter. And in most of the cases, the lesions do not show contrast enhancement. And this is an example of acute demyelinating encephalomyelitis by CT with patchy hypodensities within the white matter. And MRI is, of course, more sensitive for detection of these lesions. And you see in the T2 weighted image multiple patchy areas of abnormal signal in the white matter as well as in the thalami. And sometimes these lesions may show a hemorrhage, and this flare image is showing affection of the brainstem and multiple lesions which are deeply seated as well as superficially located in the subcortical white matter. And you know that MS do not show hemorrhage in its plaques, and of course MS has a remitting and a relapsing course, while ADAM, according to the literature, has a monophasic course with no remissions or exacerbations. And this is the case of Adam, in a 41 years old male who had the past history of 1 week deterioration in cognition and mild fever with no recent history of vaccination. The CT brain scan after contrast enhancement showed multiple patchy areas of low hypodensity scattered in the deep as well as the superficial white matter of both cerebral hemispheres. The MRI of the same case, these are axial flare images, showed extensive patchy or lesions in the white matter of both cerebral hemispheres, and the delineation of the lesions is, of course, more better seen in MRI compared to the CT scan. And this is a child, 10 years old. She has a 2 days history of lower limb clumsiness, and progressed to difficult walking with a history 2 weeks ago of gastroenteritis. Then she developed these symptoms and these MRI abnormalities. The CT scan showed bilateral parietal hypodense areas with little mass effect on the ventricles. The lesions are more well delineated and appreciated in this axial flare weighted image and also in the coronal T2 weighted image. Of course, on the follow-up of Adam, this is a regressive disease, and then this is an example. You see patches in the white matter, and after 1 year follow-up, there is evident regression in the distribution of the lesions. The clinical appearance of Adam in early stages of the disease, there is a headache, drowsiness, and fever, and later on the patient will develop neurological deficits, seizures, and the disease may progress to death. And in order to separate Adam from MS, we have the, the, the facts that MS plaques are relatively smaller in size compared to the batches of Adam. MS plaques are usually symmetric compared to the Adam plaques. MS plaques involve the subcortical white matter, and they involve the posterior fossa, and the MS has a relapsing and remitting course, while Adam is a monophasic disease. And also, you know that there may be some hemorrhage in the lesions of Adam, and hemorrhage is not a feature of MS plaques. And the differential diagnosis of Adam, of course, will include the MS, and also sometimes it may uh, be differentiated from the progressive multifocal leukoencephalopathy, which has been discussed in the inflammatory brain lesions in adults. And I have mentioned that this lesion is almost confined to a patient with AIDS, and it has a specific course and a specific appearance. And toxic and metabolic etiologies and also lymphoma may have similar findings, but in lymphoma, the lesions are usually enhancing, whether homogeneous or heterogeneous, according to the state, the immunologic state of the patient. Then we came to the toxic demyelination. We would like to handle here the osmotic myelinosis or myelinolysis or central pontine myelinolysis, vernix encephalopathy, and the effect of radiation and chemotherapy on the brain. Of course, the interaction of chemical compounds with the brain will result in temporary or permanent disturbance of the normal brain function. And this central pontine myelinolysis is a condition which is almost seen in two patients, those who are chronic alcoholics and the patients who are subjected for rapid correction of hyponatremia. And there are classic appearances in the in MRI and may be seen also in the CT scan. CT scan is less sensitive for the detection of the lesion in the bones, but it may show faint hypodensity in the central part of the bones, and this lesion will not show contrast enhancement. But on MRI, it is easy to appreciate that there is a diffuse hyperintensity in this T2 weighted images affecting most of the pontine area. And in order to differentiate this from an infarction, the diffusion weighted images will show no restriction in most of the cases in this particular area. Also, there are some myelinolysis changes in outside the bones, usually seen in the temporal lobe and in the basal ganglia. In the presence of pontine and the extrapontine involvement is almost pathognomonic of this disease. Then, if the patient has a recent surgery or have been subjected to one form of electrolyte imbalance, and then uh, this lesion can be predicted from imaging. On the axial MRI T1 weighted image, you see that the lesion is not apparent. In the T2 weighted image, you see a high signal intensity in the central part of the bones, which is also appreciated in the FLAIR image. And if you look carefully, you see it changes in the temporal lobe, and this means that you are dealing with pontine and extrapontine myelinolysis. The lesion, which is located in the bones in this T2 weighted image, has no restricted diffusion, and it was suspected to be an infarction, but the CT angiography of the cerebral circulation showed almost normal appearance of the vessels. And this is, let us say, one of the classic appearances of central pontine myelinolysis, except that you can see some diffusion restriction in the lesion. And I have said that in most of the cases you see free diffusion, but sometimes you can detect a diffusion restriction. This is the lesion in the T1 low signal, in the FLAIR high signal with some restricted diffusion. Of course, this lesion has to be differentiated from a lot of lesions, including pontine infarction, metastasis in the bones, glioma, multiple sclerosis, encephalitis, radiation, or chemotherapy effect. But we should remember that this lesion is uh, uh, is almost um, let us say, is very commonly seen in chronic alcoholics and those patients who are subjected for rapid correction of hyponatremia. And how to discriminate between this number one, the classic history, and number two, infarctions, for example, in the bones are usually to one side of the midline. And you know that infarctions in the bones will result from occlusion of one of the side branches of the basilar artery. Then you will have a focal lesion in the right or the left side of the brainstem. But in the central pontine myelinolysis, the lesion is central. It is located exactly in the midline. And number two, infarction will show diffusion restriction, while this central pontine myelinolysis will show, in most of the cases, free diffusion. And the pontine infarction may be central if the basal artery itself is occluded, and at that time you can see the occlusion of the basal artery on the MRI angiography or CT angiography. Like in this case of brainstem infarction, which involves both sides of the brainstem, and the angiographic image showed the occlusion of the basilar artery near its distal part. Then pontine glioma may have a similar appearance to central pontine myelinolysis, but there are a lot of differences. This is an acute condition. The central pontine myelinolysis is an acute condition, and it occurs in older patients, while pontine glioma has a slowly progressive course occurring in a relatively younger patient. Then gliomas usually presented by cranial nerve pulses like the sixth nerve and so. And in about 50% of gliomas, contrast enhancement occurs, and this is an indication of aggressive type of glioma, which will be at that time of the glioblastoma multiforme. Then the Extrapontine myelinolysis will occur in the basal ganglia, including the putamen, the caudate nucleus, also in the thalamus, in the midbrain, and in the subcortical white matter, and this may be appreciated in the temporal lobe. This is pontine and extrapontine myelinolysis, which is not well appreciated in the CT scan. You see some hypodensity of the bones and some hypodensity of the basal ganglia. But the changes are very well appreciated in this FLAIR weighted image and also in the T1 weighted image. After injection of contrast, the lesions do not show contrast enhancement. Then Wernicke's encephalopathy is a disease caused by nutritional deficiency of thiamine. And also this disease is commonly seen in chronic alcoholics, but can be seen in other patients. Is diagnosed clinically by a classic triad of ataxia, confusion, and ophthalmoplegia. Whenever you have the MR images and you see lesions of abnormal increased signal and the T2 and the FLAIR weighted images characteristically located in specific areas, which are the region of the mammillary bodies here and the periaqueductal region, the region around the aqueduct of Sylvius, the midbrain and the tectal plate, the posterior part of the midbrain around the aqueduct, the medial aspect of the thalami, and the floor of the third ventricle, and then the periventricular area, also as you can see here in both thalami. Then affection in Wernicke's encephalopathy is almost pathognomonic. Whenever you see involvement of the mammillary bodies, the periaqueductal area, the posterior part of the midbrain or the tectum, the floor of the third ventricle, and the area around the wall of the third ventricle or the medial part of both thalami. And this is also a classic case of Wernicke's encephalopathy by FLAIR-weighted images showing the high signal around the aqueduct, the high signal in the mammillary bodies, and the high signal along the wall of the third ventricle or the medial aspect of both thalami. And this is also Wernicke's encephalopathy, showing the appearance of the involvement of the medial aspect of the thalami, but the lower sections are needed to see the involvement of the periaqueductal area as well as the mammillary bodies. Then irradiation and the chemotherapy will result in damage of the blood vessels of the white matter, leading to their obstruction and resulting in ischemia and infarctions. And sometimes, and this is a well-known issue in the medical imaging, that focal radiation necrosis is indistinguishable from neoplasm, as I will show to you. And this is a male adult, 25 years old, who had a resected anaplastic astrocytoma followed by radiotherapy. And the follow-up scan showed a lesion which is not discriminated from glioma. You see heterogeneous contrast enhancement and some sort of surrounding perifocal brain edema. But the PET scan showed that there is no uptake within the lesion, denoting that this is a tumor necrosis, is this radiation necrosis and not a tumor recurrence. And this is a commonly seen appearance by CT and MRI affecting the white matter in the form of diffuse hypodensity of the frontal lobes. And this is commonly seen whenever irradiation is directed to the paranasal sinuses or the nasopharynx, for example. Then you see a high signal in the T2 and the FLAIR weighted images. If you inject contrast, there may be no enhancement. And this is a lesion which is not discriminated from a neoplasm, glioma, or metastasis, but the SPECT or the single photon emission computed tomography showed that there is no uptake within the lesion, denoting that it is a form of radiation necrosis. But in this case of resected glioblastoma multiforme, followed by radiotherapy of a female patient 49 years old, showing an enhancing lesion in the frontoparietal area, and this lesion showed a strong uptake in the PET scan, denoting local tumor recurrence rather than radiation necrosis. And this lesion, which is known as mineralizing angiopathy, is a lesion occurring in the white matter of patients receiving radiation and chemotherapy both. Then, and this patient with resected medulloblastoma 2 years ago, followed by radiation and chemotherapy, presenting now with headache. And the CT scan showed extensive calcification in the white matter periventricular areas as well as in the basal ganglia. The pathogenesis for this is that radiation will result in breakdown of the blood-brain barrier with damage to the small blood vessels and the subsequent high accumulation of chemotherapy agents leading to white matter damage. Then radiation disturbs the blood-brain barrier and weakens the wall of the blood vessels, resulting in a leakage of the chemotherapy agents within the brain tissue and consequently damage of the white matter, and this damage will be followed by the development of dystrophic calcification. And the mineralizing angiopathy is diagnosed in patients receiving radiotherapy and chemotherapy by the presence of white matter and basal ganglia calcification. This patient is receiving both radiation and chemotherapy for acute leukemia and presented by mineralizing angiopathy. The sites of the development of calcium include the lentiform nuclei, the dentate nuclei, and the cerebellum, as well as the corticomedullary junction of the cerebellum and the cerebrum. As you can see here, this is mineralizing angiopathy. Then I have mentioned in the lecture of cerebrovascular lesions in the pediatric age group, something about the diffuse axonal injury, which is considered a major form of traumatic injury to the brain, resulting in injury of the axons of the neurons. And this injury is related to general poor clinical status. The appearance of the lesion will be in the form of minute hemorrhagic foci distributed in characteristic areas within the white matter. And these areas are the white matter of the superior frontal gyrus, the frontal and the temporal gray white matter interface, the posterior aspect of the brainstem, as well as in the corpus callosum. The presence of these minute hemorrhagic foci in the brain tissue of a traumatized patient is diagnostic of diffuse axonal injury. And as I have mentioned, in spite of the minor changes appearing in the CT scan or MRI, the clinical picture is usually more worse. Then in some cases, by CT scan, you do not see a lesion because the hemorrhages are minute and they are not apparent in the CT scan. But MRI is much more helpful in detection of these minor foci of hemorrhage, especially the gradient images. And this is the case of diffuse axonal injury showing multiple petechiae of hemorrhage, hyperdense hemorrhage in both cerebral hemispheres, together with the presence of an intraventricular bleeding. And this is also a case of diffuse axonal injury showing petechial hemorrhages in the left temporal area as well as in the right occipital region. I have mentioned also that the brainstem function is not affected by this disease, and this disease is rarely a cause of death. Then the gradient images are helpful in detection of small hemorrhagic foci compared to the regular pulse sequences in MRI, and also compared to the CT scan. All these very dark spots are representing the petechiae, or the foci of hemorrhage distributed in the cerebral hemispheres. And diffuse bilateral multiple lesions is seen in about 80% of the cases, and the lesions occur at the gray-white matter junction, and also in the region of the corpus callosum and in the brain stem. And the CT scan is less sensitive compared to MRI in detection of these lesions, and if you use the gradient echo sequence, which is more sensitive for the detection of hemorrhagic foci. And this is the CT brain scan showing a hemorrhagic lesion in the midbrain, but it failed to show the rest of the hemorrhagic lesions in the temporal lobe, which are better delineated by this MRI T2 weighted image. And we have finished the issue of normal brain aging, the MS, the ADAM, the toxic demyelinating disease, and the traumatic lesions, and we are left finally with the vascular pathology. We'll talk about subcortical arteriosclerotic encephalopathy, and also the multi-infarct dementia, the CADASIL, and finally the vasculitis. We used to say that this brain is the brain of an old person with dilated ventricles, dilated cortical sulci, dilated extraaxial CSF spaces, denoting the presence of brain evolutionary changes which are accepted for the patient's age. But if you look to the white matter here is more hypodense compared to the normal appearance of the white matter. And at that time, we said that this is an indication of this disease, which is known as subcortical arteriosclerotic leukoencephalopathy, meaning that there is diffuse white matter ischemic changes which are related to the patient age, the presence of hypertension, and the presence of diabetes. Then, as I have mentioned uh, uh, this lecture, in the beginning of this lecture, that all these changes may be considered normal brain aging. But if the patient is symptomatic and it has neurological or motor deficits, and we have to look for recent insults. And these insults are better visualized by the diffusion weighted images. The CT scan will show dilatation of the ventricles and the atrophic changes with diffuse white matter hypodensity. But an MRI, it will show diffuse white matter high signal intensity in T2 and the FLAIR, but the diffusion weighted images will show the acute insult as a focus of restricted diffusion. Then, so we need for the evaluation of patients having recent ischemic insult to be examined by MRI, including the diffusion weighted images. And this is subcortical arteriosclerotic encephalopathy by CT and by MRI FLAIR weighted images. There are diffuse changes in the white matter, hypodense in the CT, high signal in the FLAIR weighted images. And of course, these changes can be included in the differential diagnosis of brain metastases. And metastases will enhance, and there should be a history of primary malignancy, vasculitis, and the primary CNS lymphoma. Lymphoma also will show contrast enhancement, which will depend on the immunological state of the patient. Then if you have the diffusion weighted images and you are able to specify that this is an acute insult, which is seen here and here because of the evident restricted diffusion. In multi-infarct dementia, which is known also as subcortical arteriosclerotic encephalopathy or Binswanger's leukoencephalopathy, or Binswanger's disease or vascular dementia or arteriosclerotic dementia, all are these names for the same pathology. And the multi-infarct dementia is uh, seen in old patients and presented by the previously mentioned changes in the form of brain evolutionary changes and sheets of high signal intensity surrounding the ventricles, the deep white matter, foci, and the patches of high signal intensity in T2, and flare weighted images representing ischemic white matter changes. And this is a female patient, 75 years old with dementia, showing typically changes in the T2 and the flare images. The ventricles are slightly dilated. There are sheets of high signal intensity framing the ventricular wall and scattered foci of high signal intensity representing white matter infarctions. Then we came to this disease, which is known as CADASIL, and this is the abbreviation of cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. This is the CADASIL. This is from its name is an autosomal dominant vascular dementia, which is related to a gene mutation, and it is exactly similar to the changes seen in the subcortical arteriosclerotic encephalopathy, but in these patients, the changes occur earlier in the life. They are seen in the range of the third and the fourth decades of life, and the disease has a progressive course to death around the age of 50 to 70 years. And one of the important criteria of this CADA seal, besides its relative younger age incidence, is the presence of affection of the temporal lobes. And this is, if you remember the subcortical arteriosclerotic changes, they are rarely seen in the temporal lobes, but they are seen in the white matter around the ventricles. The lesions uh, are similar to the subcortical arteriosclerotic encephalopathy. Most of the patients will present by recurrent transient ischemic attacks or strokes in multiple vascular territories, and eventually the patient will go into the dementia. The diagnosis will depend on three issues. Number one, the younger age of the patient. Number two, the changes which are evident in the temporal lobe beside those changes in the deep white matter. Number three, the genetic identification of the mutated gene. And the lesions of CADASIL are located in the frontal lobes in about 93% of cases, the temporal lobe in about 86% of the cases, and the subinsulae white matter, which is also in the temporal lobe. Then if you see a patient who is relatively younger in the range of 30 to 40 years old, and it has the subcortical ischemic changes similar to an old patient in the 60 or 70 years of his life, then you may think of this CADASIL, which is confirmed after the detection of the mutated gene. And this is the difference between CADASIL and the subcortical arteriosclerotic encephalopathy. The patient is relatively younger here, and the changes do not affect the temporal lobe in subcortical arteriosclerotic encephalopathy, but the changes are evident in the temporal lobe, and together with the detection of the mutated gene. And this is CADASIL. The white matter lesions appear by the age of 20 to 35 years, and these lesions will be present without any symptoms until the age of 35 years. Then symptoms begin to appear, and the number of the lesions, and the seriousness of these lesions will increase by the increase in the age. Then, in order to predict that you are dealing with a CADASIL, then number one, the patient is young. Number two, there are lesions in the temporal lobe, and the genetic assessment will detect the mutated gene. Finally, we have few words about vasculitis, and vasculitis is seen in patients with autoimmune diseases like systemic lupus, Sjögren-based, moya disease, polyarthritis nodosa, and in some cases also of amyloid angiopathy. In the previous days, we used to report the case as vasculitis whenever we see brain lesions that are multiple, and some of the lesions are hemorrhagic and other lesions are not hemorrhagic in a relatively younger patient. Then we think of vasculitis, and we search in the clinical picture of the patient to find any of these diseases which can explain the picture. But actually, if you know from the clinical history of the patient that you are dealing with one of the lesions that are responsible for vasculitis, then the diagnosis will be easy. If you are dealing with systemic lupus erythematosus, polyarthritis nodosa, Behçet disease, and the explanation of these lesions, which are hypodense lesions um, in the temporooccipital area, high signal in the T2 and the FLAIR weighted images, is easy as vasculitis. One of the well-known types of vasculitis is the moya disease, which can present in two forms, the primary and the secondary or the acquired form. The primary form is an idiopathic, slowly progressive disease involving bilateral occlusion of the supraclinoid portion of the internal carotid arteries. And this will result in the development of many collateral vascular channels, which will appear on imaging like the puff of smoke. And this is a characteristic appearance of primary moya disease in MR angiography, showing absence of the middle cerebral and anterior cerebral arteries on both sides, which are replaced by this huge vessels, dilated tortuous collateral vessels, representing or mimicking the puff of smoke. This is the normal MR angiography of the cerebral circulation. This is the anterior cerebral, middle cerebral, posterior cerebral. But here you see only the internal carotid. You don't see the anterior cerebral, the middle cerebral, or the posterior cerebral, which are replaced by this network of dilated tortuous vessels. And this is also an image which is diagnostic of moya disease. This is the normal appearance. Here is the internal carotid, middle cerebral, anterior cerebral. And here you do not see any of these vessels. Instead, you see very small micro vessels present in the supracellular area. They show signal void appearance, and this is a classic picture of moya disease. And this is the MR angiogram. You see the internal carotid, you don't see the anterior cerebral or the middle cerebral or the posterior cerebral. And these MR images are almost typical for the diagnosis of moya disease. In the region of the basal ganglia, in the region of the sylvian fissures and in the deep parietal area, and also in the supracellular area, you see this micro vessels showing the signal void appearance, and you cannot appreciate any of the major cerebral vessels. In children, moya disease will result in infarctions, while in adults, moya disease will affect the white matter, leading to ischemic white matter changes and sometimes areas of hemorrhage. In both cases, the cerebral atrophy is seen in about 50 to 60% of cases. The secondary moya disease, in which the occlusion of the vessels is secondary to a pre-existing disease, and these are the neurofibromatosis type 1 and the sickle cell disease, and also the sequelae of radiation, as I have mentioned before. Alhamdulillah Rabbil Alameen. Thank you.